Good day, everybody. Welcome back to the Peptide lecture series, or rather, the first lecture in the Peptide lecture series. In today's one, we will be covering the GLPs, namely Semaglutide, Tirzepatide, and Retatrutide. We're going to discuss what they do, typical dosing protocols used, um, and essentially what they're developed for. Disclaimer, this is not medical advice. This is for educational and entertainment purposes only. Any medication or lifestyle changes that are made should be done with the advice and consent from your treating primary doctor. Alright, let's begin. So what is GLP? GLP, which is short for glucagon-like peptide, we normally call it GLP-1, is a naturally produced hormone in your intestine. It's produced after eating to help signal insulin to release, suppress excess glucagon production, slow gastric emptying, and to increase satiety signals in the brain. The net effect it has is well-balanced glucose control and reduced hunger after a meal. GLPs, in the context of the drugs, aim to mimic the hormone's effects or replace it entirely. The main issue with GLP itself, because you may think, why not just make more GLP? GLP is quite a short-lived molecule, so it doesn't stick around for hours and days. It's also quite genetically variable. Some people produce a lot more GLP than other people with a lot less food than other people, which is why some people are more prone to obesity than others. So what are the actual drugs that work here? As of this lecture, there are three main GLP drugs and one precursor drug. They were initially made for the treatment of type 2 diabetes, mainly by lowering your HbA1c, reducing glucose spikes, and improving insulin efficiency, so your body needs less insulin to do more. Side effect of these were often significant weight loss because of the satiety effect of GLP. And some of them even reduce the dopamine reward response that gets triggered by junk food. Nowadays, the FDA has approved a few of these, not just for diabetics, but also for general weight loss. And many of the drugs also seem to show some promising effects in other forms of metabolic and cardiovascular health. All right, so like we said, we have three main ones and then a precursor. So the precursor is called Liraglutide. It requires a daily injection and is a GLP-1 agonist. It's an agonist. It means it stimulates the production of those molecules. Then the ones currently in the cultural zeitgeist are our Semaglutide, brand name Ozempic. It's a weekly injection and was developed by Novo Nordisk, initially for type 2 diabetes. Tirzepatide, called Mounjaro, brand name, is a GLP-GIP agonist, which is also weekly injection, developed by Eli Lilly. Then Retatrutide, still in clinical trials, is a GLP-1, GIP, and glucagon agonist, and is also a weekly injection. As a bonus, we have cagrilintide. It's not a GLP-1, but it provides similar satiety effects by being an amylin analog, and is also still currently in clinical trials. Okay, so liraglutide is the older generation, less long acting, needing daily injections. It's good, it works, but it's not as potent as some of the others. Typically, the dosing schedule is 0.6 milligrams daily, increasing in 0.6 milligrams increments every week until 3 milligrams daily, or whichever highest dose is best tolerated for the desired effect. Then we get semaglutide, aka Ozempic. It's stronger than liraglutide and longer acting. It has a stronger appetite suppression, and this leads to greater weight loss. The dosing is normally 0.5 milligrams weekly for 4 weeks, and then every 4 weeks increasing to 0.5, then 1, then 1.7, then 2.4. 2.4 is normally the maximum that people stop at. This dosing schedule is based on clinical trials, but practically it needs to be individualized because for some people, jumping from 1 milligram to 1.7 milligrams within the span of a week has GI side effects that are unpleasant. For some people, they may have excellent weight loss at 0.5 milligrams, so if they are happy with the progress, they don't need to go up to 2.4 milligrams. Then we get Tirzepatide, called aka Mounjaro. It's a GLP-1 agonist, like we discussed, and then also a GIP agonist. So what's GIP? GIP stands for glucose-dependent insulinotropic polypeptide. Eli Lilly adding this agonist in improves insulin sensitivity, increases adipose signaling to release fatty acids, and because it's both of these, you need less of each of them to achieve the desired effect. So often, people on tirzepatide can tolerate higher drug doses than just Ozempic alone. Yeah, and oftentimes in the research, the GLP-GIP combination very often exceeds just GLP-1s for weight loss. The typical schedule is 2.5 milligrams weekly for 4 weeks, and then again, just like Ozempic, you increase it by 2.5 milligrams every 4 weeks until you get a maximum dose of 15 milligrams. Or if you're happy at 2.5, if you're happy at 5, if you're happy at 7.5, you don't have to go up. Then we have Retatrutide, also called Reta in online circles, currently still in clinical trials as of this lecture. Sometimes it's called GLP-3 because it involves 3 pathways: GLP-1 agonism, GIP agonism, and glucagon receptor agonism. The net effect of these 3 is satiety and lowering caloric intake with increased energy expenditure and increased fatty acid oxidation. The dosing doesn't have any formal publishing on it yet, but like with the others, it's normally the 4 weekly titration, commonly up to a maximum of 12 milligrams. So what does glucagon actually do? Glucagon is a pancreatic hormone that raises your blood sugar. Why does it do that? Because it triggers the release of glucose from your stored liver, i.e. it tells your liver to convert stored glucose from glycogen to glucose, which can be used for energy. And then also it helps with gluconeogenesis, which is creating glucose from non-carbohydrate precursors. So what are the side effects for these drugs? So like we said, these are incredible for weight loss and diabetic control, but no drug, unfortunately, is without side effects. Our typical side effects include nausea and vomiting, reflux, constipation, and then excessive appetite suppression can cause nutritional deficiencies and accelerate the loss of lean mass instead of just fat mass. The side effects are very easily managed by increasing the time frame between up titration or decreasing the dose to a more tolerated dose with still desired effects. So practicality, what is it for? It's for obesity, type 2 diabetics, insulin resistance syndromes like PCOS, people at high risk of non-alcoholic fatty liver disease, and people with poor satiety signaling who are oftentimes obese as well. It's not recommended for use in people with pancreatitis, a history of gastroparesis, a history of gallbladder disease, in people already underweight, or in those who are frail. So, what are some tips and tricks to actually minimize the side effects? Dietary-wise, aim for a high-protein diet, at least 100 grams of protein daily to maximize your satiety signaling and increase your lean mass retention. A high-fiber diet, minimum of 25 grams of fiber daily. I said protein there, but it's supposed to be fiber, to reduce your constipation risk and increase satiety. Also drink lots of water, else the fiber is going to feel terrible making its way through your digestive tract. Limit your fat intake. Because fat is slow digesting, it can cause unneeded reflux and nausea and sometimes vomiting, especially in people who are on higher doses. Then, very important, resistance training. However you want to do it. Strength sports, weights, calisthenics, bodyweight exercises, as long as you're doing something to stimulate muscle growth and stimulate lean tissue retention, most of your weight loss will come from fat instead of muscle. So what are good food options? We want to maximize our quality protein. So we want to choose lean meats like chicken breast, turkey, lean beef, and venison. Steak, if you want to have steak, great. Just don't go for a ribeye. Rather have something like a sirloin or a filet mignon if you have the money. Fish, white flaky fish are very great, like hake, cod, tilapia, angelfish. Fatty fish like salmon, trout, mackerel, sardines. And then I like to call this the meaty fish like tuna and yellowtail. And then other good quality sources are low fat and fat free dairy and eggs. Then to maximize your fiber intake, legumes and beans. Great. They also contain high amounts of protein. Not necessarily the best quality, but when combining different types of legumes and obviously adding it to meat dishes like in a chili, best of both worlds. Eat a variety of fruits and vegetables to get as many nutrients in as possible and to try and maximize your fiber. And then if you are vegan or vegetarian, the best of both worlds is TVP, what's called soy or textured vegetable protein. It's a good quality protein source with all the essential amino acids you need, and it has a lot of fiber in it as well. And if you make it right, you can't even tell the difference between that and ground beef. So in summary, Liraglutide was your daily GLP. Semaglutide was weekly, but stronger. Tirzepatide is a dual incretin agonist. And then Retatrutide is a triple metabolic agonist. All of these drugs work best when combined with high protein, high fiber diets, and resistance training. So they act via direct hormone signaling to increase satiety and promote weight loss, rather than relying on appetite suppression by use of stimulants like traditional fat burners. So what do we have in the future? As it stands right now, Eli Lilly is producing an oral synthetic GLP-1 hormone, which is essentially Ozempic in a pill. So this is called, so the brand name is called Foundeo, and the generic has a very long name that I can't remember. I actually think as of the recording of this lecture, it might be released to the public. But it's a synthetic GLP-1 molecule that's been modified to avoid breakdown. It's a once daily dose. Taking it with or without food doesn't matter. Time of day doesn't matter. It's just a once daily dose, which for many people is very nice, especially for those who don't really want to be injecting themselves. Retatrutide, as of the recording of this lecture, is in its final phase of clinical trials. And then there's also others like your Liraglutide that are in the works as alternative fat loss drugs. There are some companies combining the different agonists, such as Liraglutide and Semaglutide, calling it CagriSema, so you get the benefits of the amylin and GLP-1 appetite reduction. And then While it's not recommended, some people combine these with stimulants for enhanced appetite suppression. Please do not do that. Please. Please. Retatrutide especially already causes a raised heart rate above your base. Not necessarily a tachycardia, but it very commonly increases your resting heart rate by 8 to 10 BPM. If you combine that with caffeine, can give you problems like palpitations, make you feel anxious, sweaty, things like that. So rather choose one, please. And yeah, that is essentially uh, the GLP-1s summarized. Thank you so much for listening, and we will see you in the next peptide series lecture.